So I want you to talk now. We're going to talk to the nephrologists themselves, the guys that are at either the ER, they're at the primary care, they're at the nephrology clinics, they're wherever they are, these doctors, right? And they're seeing patients crash into their offices with this life-changing disease that they know nothing about. Okay. What advice do you have for the hospitalists or nephrologists who first encounter a nephrotic patient?
Yeah, I think you have to realize, I mean, getting all of the baseline information is important. So what is the kidney function? What is the blood albumin, as we talked, how much protein of urine? Nephrotic syndrome, the cholesterol can go sky high too, and that, is a long-term risk. So sort of getting the basics and realizing, is the kidney function significantly different than it was last time we checked? That may be someone who has acute kidney injury on top of the nephrotic syndrome or has a renal vein thrombosis. So that can push sort of the acuity of, do I know enough to manage this, or do I need to get my colleagues to help very quickly? I think any nephrotic syndrome should be seen by a nephrologist, either at that visit or within the next week or two, because there are life-threatening risks, especially the blood clots, and treatment needs to be started. I mean, there's some annoying factors like the swelling, the fatigue, the sort of overwhelming fatigue that patients can have. That's not life-threatening, but there are things that you need to get therapy started very quickly. So finding a colleague who knows what this may be, what to do about it quickly, I think is very key. And realizing that it could be the kidneys, because as I said, I've had patients who've had the leg swelling, and the first thing is to set them up with a cardiologist because they're afraid of heart failure, never thinking about the urine might be causing this, the kidneys.
They did that to me when I was diagnosed in the heart of COVID. Not only did they think it was COVID, because COVID had no symptoms at that point, there was nothing confirmed. They're like, I don't know, anything could be COVID. Remember that? They're like, if you sneeze, I think you probably got COVID. So when I crashed into the hospital with my disease, that's exactly what they did. And every time after that, right? So when I would get discharged from the hospital, I'd go home, I would do my own routine of trying to manage my own water weight and that kind of stuff. And I would end up back in the emergency room because the water would get too much, and the weight and I'd have to go get another albumin injection. It quickly turned into a conversation of, when I presented myself at the ER, this is not a heart attack. This is not a heart thing. I have a kidney disease. So it was like a script almost, right? Like I walked into, it was like, hi, this is my name. I have membranous nephropathy. It's a rare autoimmune disease that affects my kidneys, and I'm in a lot of pain, and I'm swelling, and I'm retaining water, and I need these drugs. And I have to have albumin, and I need some kind of Lasix, and I'm probably going to need to be admitted for probably the next 2 days so I can dewater. That's the conversation you have over and over and over, right? When you get there, because so many times you get misrepresented. And then the patient themselves are in so much pain, right? Like, think about this, the state of when we have to go to the hospital. Like, all else has failed. Everything we have at home, all of our support system we have at home has now failed. And now we're emergent, and now we're in an emergency room, and we're expecting some type of relief or answer or mitigation to what I'm experiencing. But yet I have to come in and be the educator in that moment, unfortunately. And that's just some of the willpower that we're trying to teach our following and teach our patients, that we have to crash. When we do crash into there, it's okay. And it's okay to be the educator, because that's what we need to get. We need to get the relief, and sometimes just having the guidance, right? Or knowing what to say when and to who. To the floor nurse or the floor doctor, they're going to come in 8 times. What's wrong with you today? And you're like, I don't know. So anyway, I think that's a really good way of nephrologists attacking this when they see it. They can see it in the form of heart disease. They can see it in the form of lower EGFR. They can see it in the form of water retention and pitting edema. They can see it in the form of blood clots we talked about, and maybe a renal thing, RVT. It's not even a physical ailment.